listening to Ailsa talking about the importance of getting outdoors, that is really, really important to me. And this is, for those of you who may not be aware, this is What Matters to You Day. Did any of you know that? Yep. And in the Alliance, we had a big board up on the wall, and we were to write what matters to you, or what's important to me. And one of the things I wrote down was getting outdoors and my ability to exercise, hill walking, getting fresh air. So I absolutely sort of endorse everything that Ailsa had to say there. I live in Glasgow now. I live in Pollokshields, and for those of you who don't know, Pollokshields was the first sort of garden suburb in the UK, so I'm very fortunate. Within about 10 minutes walk from my front door, I've got Pollock Park, Bellahouston Park, Maxwell Park, and that sort of really allows me to be outdoors and to connect with nature as often as I possibly can. And being a Highland lass, that is very, very important to me, so it's particularly nice to be back up in Inverness, the city of my birth. So there you go, and I'll probably slip back into my Highland accent as the day goes on, my Skye accent as the day goes on. So first of all, as I mentioned earlier, I work with the Health and Social Care Alliance. Are we all familiar with the Alliance? No? Okay. The Health and Social Care Alliance, it's a membership organisation, and our vision is that for Scotland, it's up there, and it's quite plain English. It's a vision for Scotland for people who are disabled or living with long-term conditions and unpaid carers have a strong voice and enjoy the right to live well. And I think none of us can argue with that. And whether you're living with a long-term condition or whether you're supporting somebody living with a long-term condition, you absolutely want that person to sort of live as well as they possibly can. And what the Alliance does, it's sort of brought together an extensive and diverse sort of range of organisations. And people, so it's organisations who are either interested in supporting people's long-term conditions or directly involved in supporting them or represent them, or people living with long-term conditions or their family members. And the core aim of the Alliance, and I'll just read this from their annual report, which I've got here, is to ensure that people are at the centre, that their voices and their expertise and their rights drive policy and sit at the heart of design, delivery and improvement of support and services. The second aim is that we support transformational change towards approaches that work with individual and community assets, and that's where we all come into it, helping people to stay well, supporting human rights, self-management, co-production and independent living. And then I think partly where my role comes into this to a certain extent is championing and support the third sector as a vital strategic and delivery partner and foster better cross-sector understanding and partnerships. And I think we all agree, everybody in this room will have no doubt whatsoever that the third sector has a huge, huge part in supporting people live well with the long-term conditions. I don't think anyone will really disagree with me. This figure is slightly out of date, actually. We've now got 2,702 membership organisations, so that's a lot of people. And I think when I was sort of talking about supporting people living with long-term conditions, just want to clarify what we mean by support. And this is a definition by Professor Vicky Entwistle, and it's the purpose of support is to ensure that people have what they need to be able to live and die well on their own terms with their long-term conditions. And I think the whole ethos of House of Care and the model of houses of care is supporting people to be living within their own terms. I'll come into that in more detail when I'm discussing the model in detail. But obviously, we don't do this, the Alliance doesn't do this in isolation. In Scotland, we have thousands of policies and procedures. Well, it feels like policy, that thousands of them. We have lots of policies and structures, and a really sort of good, we may not think it at times, but a really, really good health and social care system which allows us to do this. And when I mentioned the vast number of policies, you've got here, you've got Our Voice. I'm sure a lot of them will be familiar to a lot of you. We've got More Than Medicine, we've got Gone Yourself, which was really the first document that really supported self-management. We've got the GP contract, we've got Realistic Medicine, we've all sorts of them. But I think the main theme that comes across right through all of these ones is self-management, sort of shifting the balance of care from acute sector into the community, and certainly shifting the balance of care to the people living with long-term conditions are really in control of what they're doing. And this all comes at the back of in 2011, when the Christie Commission was published. This called for people and communities to be engaged and involved in the design and delivery of public services. And I think we all, I don't want to insult anyone by the room, but I think most of us were working in 2011, so we'll be familiar with what the content of that Christie Commission was. And we really wanted people to be a move towards embracing more social rather than medical models of care, and that's very much what Elsa referred to in her presentation. And I've been sort of fortunate enough to be in a presentation delivered by the sort of self-prescribing and the social prescribing team in Dundee. This was a good few years back, and it made absolute common sense to me. And this was all round about the time of the sort of health and social care integration. But really, at the heart of this, the whole heart of sort of enabling people to be more in control and enabling people to be involved in the design of the new models of care and whatever, is collaborative conversations between people, that's us, and healthcare professionals, which is probably also us as well. But at the end of the day, when I say people, I'm talking about people with long-term conditions. But all these policies that are up on the screen there, what they've all got in common are self-management, as I mentioned earlier, shifting the balance of care, sort of cross and sort of multi-sectoral working, and a sort of care and support planning, which is really the core of House of Care model. But sort of most importantly, and I can't emphasise this enough, is keeping the person at the absolute centre of all decision making. And that's decision making around policy or delivery, but certainly around their own, the care and support that they're getting. I think that the two sort of policies up there that sort of stand out for me are sort of the Go On Yourself, which was written by people, not by civil servants, as a lot of these sort of policies are, and Realistic Medicine, and that was written by Dr. Catherine Calderwood, the Chief Medical Officer for Scotland, no doubt with some input from civil servants as well. But I think rather than sort of reading out what is on this, I think you'll pick out that again the sort of the key element are combining the expertise of patients and professionals in a more equal partnership. And this sort of shared decision making is coming through every policy that comes out now from Scottish Government. And the reason that this is so important, this ability to self-manage and this sort of shared decision-making process is so important, is that people with long-term conditions are living with that condition 365 days a year. You're wondering, what on earth is that? It's not a caterpillar, it's not a snake. What it is, it's a diagram or a drawing that was sort of made by a person who's living with a long-term condition during our World Cafe session that was held when looking at sort of care and support planning in its early days. And what this person is saying is that the green line, that's their life, where their medical condition will be going up and down, up and down. And that will be the same for any condition. The red lines are when they've got the intervention with the healthcare professional, whether it's going to GP surgery and meeting with the advanced nurse practitioner or the GP or the practice nurse who's leading that particular clinic. So that could be the diabetic clinic, it could be the respiratory clinic, it could be whatever. And what that person has said, and what lots and lots of people will say, that it's more often than not, if they're going to have a crisis, it's not going to be on the day that they're meeting their GP or the practice nurse. It's going to be one of the squiggly times in between times. And what we also know is that they've said that their care isn't joined up. So what this sort of House of Care sort of model and this sort of care and support planning model, it sort of really gives that person with the condition the knowledge and the confidence and the resources to live well with their condition throughout the year. And how do we achieve this? And this is what you've all been waiting for, is when we discuss the House of Care model. And basically, in its simplest term, the House of Care model helps make sense of the key element that enables people live well in their communities. And this is sort of based, for those of you who've got sort of an interest or like a more of a clinical background, this is sort of based on Wagner's sort of clinical care model. and has been, which is a bit complicated and not a particularly nice image. When I say nice, it's not particularly aesthetically pleasing, or easy to understand. But his model was adapted by the Year of Care Partnership in England, and they were related to the pioneers of care and support planning, and they sort of adapted this model originally to support people with diabetes. Most of the people within the team were originally diabetologists, but now it's been developed and supported, developed to support people with all long-term conditions. And the Year of Care, who are based in the north of England, along with Scottish Government, are the Alliance's key partners in this programme. So to working alongside us, we've got Dr. Graham Kramer, who's our clinical lead, and we've got two colleagues from Scottish Government, both in the primary care and sort of health literacy department. And why is it called House of Care? It's because it looks like a house. And that's sort of really a simple visual model which is built around that sort of care and support planning conversation that I've mentioned. And really, like as with any building or with a house, it has to have a roof. I usually have a pointer to point here, so I'm waving my arms in the air instead. It's got a roof, it's got two walls, and it's got a foundation, and it's got the centre, or got the heart of the home. And without any, if you were to take one of the walls away, the house would collapse. If you take the foundation away, the house would collapse. So this shows that it's very, very much a team support, a team approach, very much a multi-sectoral approach, and very much a sort of approach where everybody is seen as having an equal role to play. But I think that the part that I keep emphasising is, but at the absolute centre is that sort of care and support planning, and keeping the person that we're supporting sort of at the absolute centre. So where you've got the roof, you can't really see it there with the light in here, but what the roof has got is I'll start with the roof, is the organisational processes and arrangements. So that could be the GP practice, it could be the hospital clinic, it could be the NHS 24 if that's where somebody has to go if they are having a bit of a crisis. It's the IT, it's all the policies, it's all the structures, it's all these sort of hard things that we all rely on to work with. It could be, it could be at GP level, it could be at Health and Social Care Partnership level, or it could be at board level, or it could be right down to the diabetic team within that practice. So that's very much the processes, and the structure and the arrangements. On the right side, you've just about made that out. We've got the health and the care professional and a team. So that'd be anyone within the practice team generally. So that's a GP, the practice nurse, healthcare assistant, the admin, and they are sort of, there'll be a slide, not the next slide, but the slide after, we'll break that down even further. So on the right-hand wall, you've got the staff, and that's the staff who are engaging with the person and their family. On the left-hand side, you've got that sort of represents the people with a condition and their family members or their carers. And that's a group of people who are absolutely ready to engage about sort of their health and social care in their way, which they found to be empowering. And it's about supporting them sort of manage and self-manage their condition. And they're doing that sort of using the sort of principles of co-production with the healthcare professional. And then at the bottom, you've got the foundation of the house, and that's the wider community support. And that's the More Than Medicine, and you'll hear me referring to More Than Medicine. You may be familiar with that already. But that's the More Than Medicine that Catherine Calderwood has refers to in her Realistic Medicine reports. And it's that sort of part that is really where the Alliance comes into it, and that's really supporting the third sector organisations that are delivering these sort of social prescribing services, or the More Than Medicine or the non-medical elements of the support. But it's essential, again, it's at the very, very heart of this house. It's the conversation, and it's during this sort of conversation that the support, based around what matters to that person and their families, is discussed. So with this model, you've really got a change in dynamic between the relationship that traditionally would be that the person with the condition going in to see the practice nurse or the GP, having 15, 20 minutes, if they're lucky, to see how they've been in the last 3 months or the last 4 months. Tick, 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 take all the bloods, do what checks need to be done, then away you go. That's the old process. With this approach, the person is coming in for a pre-assessment appointment, and that's where they meet with the healthcare the healthcare assistant. And that's where they have any sort of a test done, whether it's a blood test done or whether it's a blood pressure or it's weight or whether it's a feet checked or whatever. But that's when the results that's when the investigations are taken. The person is then sent a letter with the results on it. So they have got time to analyse and sort of look at the results to see how they compare to the last time they were in. But the key part of this, that they have this sort of a very simple sort of form to complete. And if I had more time, I would go through the form in detail with you. But really the key element of that form is what matters to you, what is important to you, how does your illness impact on your life, what support would you like or feel you need that will help you live as well as you possibly can with your condition. And it might say that no, that there has been an increase in your weight since your last appointment. No, why? No, why? Is there a reason for that? Or it could be the person's been on holiday for 2 weeks on an all-inclusive trip to whatever, and they've been eating and drinking and not exercising with the normally the ability to exercise. But it's really given that person time to look at the results and think about their impact their illness is having on them and how they want to be in control and what really is, what are the important things that really matter to them and how their illness impacts on that. So there's really quite a dynamic sort of change, and I think it's really a fundamental shift in the relationship between the person with a condition and the professional that's supporting them. And I think this is particularly fitting today with it being what matters to you, Dee. So traditionally it used to be, what is the matter with you? But now it's, what matters to you or who matters to you? And that's the key thing. Asking about what matters to you. It could be somebody who's living with diabetes. It's not particularly well controlled, but they're also the main carer for their husband or their wife or whoever who's got dementia. So they might not be too bothered about their diabetes, but it's what matters to them is how they manage to support their loved one with dementia. So that's just an example. Whereas traditionally, when the person would then go in for their review meeting, the focus will be on the diabetes rather than the effect that's having on that person's ability to care. This is a bit cluttered. I'm not going to go through it in a huge detail because it's quite difficult to read, but it's really sort of building back up in what I sort of mentioned earlier on. When you've got the right-hand wall, where you've got the healthcare professionals, it's not just having the person being there, but it's that person having the educated and self-management principles, having the clinical expertise to support that person, being a member of the multidisciplinary team, sort of having sort of the ability and the confidence in allowing that the person with the condition to sort of take control, for want of a better expression. The other side, you've got the patient who has had their pre-consultation results. They've got access to what the results were, what they might not have had before. They've had the shared correspondence beforehand, so that they're going into their appointment with the nurse or the GP sort of much better equipped than they had been before, and they've got the support from sort of people round about them to take the lead. But it's this bit at the bottom, the more than medicine bit that the Alliance is particularly focused on, and I'm particularly focused in my role. And this is really the informal and the formal support that more often than not is delivered by third sector organisations. However, for this to work, general practice staff have to know what resources are out there, and I think that came up in the previous presentation, is that GPs in particular don't always know what third sector resources, either informal or formal, or what opportunities or what community assets are out there. And I think, and that's not a criticism of GPs, because there's lots of things that they do that we don't know about, but I think that is a fact. But for this model to work, and for social prescribing and for self-management to really work, everybody that's involved in care and supporting people with long-term conditions really have to know what's out there. And one of the ways that we do this in the Alliance and is by having what we call more than medicine events. And they've been delivered in the areas that the health boards who have adopted this approach. Again, I think it's probably slightly easier to read that one. They're events where the Alliance or me will pull together. Say, for instance, I'm going to use Highland as an example because this is going to be happening in autumn. Highland, so a group of GPs in Highland approached us a good few months ago to say that they were interested in learning more about this house of care model. It's had quite a lot of coverage recently because GPs in particular are looking at it because it very much ticks a lot of the boxes and helps them sort of work following the principles of the new GP contract. And Catherine Calderwood has mentioned the house of care approach in her realistic medicine sort of report around this is really an ideal model that supports this whole sort of care and support planning approach. So what we do is there was a taster session delivered in Inverness in the beginning of June for GPs and practice staff. And that was delivered by Graham Kramer, our clinical lead, and the Year of Care sort of team who came up from Northumberland. And they sort of gave a presentation on this approach. And so it looks like we're going to be getting the go-ahead. There's going to be training being delivered to practice staff I think it's going to be in Aviemore in the beginning of August, because it was an Nairn practice and practices in Badenoch and Strathspey who are particularly interested in this. So on the back of that, I'm going to be arranging, hopefully with representation from quite a few folk around the table, certainly one event to begin with, and then another one, depending on how that goes down, event for practice staff. And the whole aim of these sort of events are really to strengthen the link between general practice and third sector organisations in the area, and to raise awareness of the link workers, to raise awareness of ALICE. Is ALICE being sort of used in Highland as a resource, or do you don't have another one?
The last I heard was the last update actually removed all
Highland data. Okay.
I don't think there's anything from Highland on it.
I've added my stuff onto it. I think a few organisations.
Yeah, good. Yeah. If it's an area that ALICE is alive and kicking, would obviously be sort of inviting folk from ALICE along, or whatever that resource is for sharing information. So the key aim is really to. Sorry.
What is ALICE?
Oh, ALICE. Oh, goodness me. I say ALICE all the time. A local information system for Scotland. Yes, thank you. My mind always goes black. So it's really an online resource, and it allows you to see what resources are available within your area. ALICE has got sort of strengths and weaknesses, and I think that's probably another conversation. But really the overall aim is to bring all the third sector organisations together, and the general practice staff and any other sort of healthcare professionals might be interested in knowing what resources are available. They tend to be sort of short and sharp sessions, usually over lunch. We usually serve just soup or sandwiches or tea to get folk along. And certainly feedback from previous events show that sort of general practice staff have reported like an increase in their awareness of what's available within their areas. And you can see like the graph at the bottom, that the one was the yellow at the bottom was pre-event, the green was post-event, and it's really that's just indicating I'm aware of what third sector and community organisations in my area do and how they provide people with support. So that's a fairly straightforward sort of way of doing it. So these more than medicine events have been held around the country in the areas that have adopted this model. But going back to care and support planning, we know it works. And I'm can say that sort of quite confidently. We've got this report here that was issued in 2012, and this was a learning report of where we were in Scotland. I wasn't part of the process at this point, so it's a royal we at this time, and that's got quite a lot of sort of really good sort of case studies and some information on the model sort of in practice, a bit about the history behind it, and it's a really good, really interesting read. I've got 10 copies there, so please feel free to help yourselves. But what if you pick one of them up and read it? No, we know it works. We know it supports self-management and puts people in the driving seat of their care. We know it improves coordination of care. We know it improves personal health outcomes. We know it improves health service use. What we've seen is with there's a reduced tendency for people with long-term conditions to present at A&E out of hours, or to phone their GP practice out with their, for sort of condition-specific sort of reasons, because they've got that knowledge and that confidence to manage their conditions. And I think overall it sort of improves the care experience of both the people with a condition and professionals involved in their care. And this is a really simple quote from June, who is a patient or a person, I don't like the word patient, but a person in Grampian, and that just sort of sums it up very, very, very nicely. It also benefits patients, but also GPs as well. Like Sue Arnott is a GP in Lanarkshire, and she has said, we're on an even footing now, and that's so powerful. And that's really like the shift in dynamics that I've mentioned about the person being in more control and feeling much more empowered to sort of take the lead during that consultation appointment on what matters to them and sort of accessing support. I think what we have found is some, please don't quote me on this, but some maybe older style GPs have practiced maybe an older style of medicine, aren't quite so comfortable with the support initially, because they're just not, they're very much used to the person sort of doing what they say, or listening to what they say, or just believing what they say is correct. But I think once they come round, they realise that the benefits are quite significant. I mentioned there that Highland are hopefully just about to come on board. We'll be having our first cohort of practice staff going through the training on how this model is introduced, and it's like a day and a half's training, and that'll be for all the practice staff involved in the process, and that's an introduction to like the philosophy, the documentation that's used, and just to support them sort of sometimes with their listening skills, or there's a different approach, using sort of different consultation style than perhaps they had done before. But this was really first brought to Scotland in 2013-14, and to Glasgow, Lothian and Tayside, they were the pioneers in Scotland, or the early adopters, whatever you want to call them. They were followed sort of fairly swiftly by Lanarkshire, Ayrshire and Arran and Grampian. And now I see Highland is hopefully coming on board. We've done a recent taster session in the Western Isles, and Borders and Dumfries and Galloway are certainly very interested, and we've been down and we've had meetings with them. And I think our aim, probably unrealistic, but our aim would be, what we would love to see is this approach being adopted throughout the country. And certainly one of the key elements of my role, apart from really in promoting and supporting third sector engagement, and really sort of showcasing and supporting third sector organisations, show what they can do and the important role they play. It's supporting the spread and sustainability of this approach. I'm looking at my watch, Ian, I've got a minute to go. But I can't really talk about House of Care and care and support planning without making reference to my colleagues within the Alliance, the people I work very, very closely with. One being the Alice team, who I share a room with, but it's the community link workers, and Ailsa mentioned them. I'm based in Glasgow, as I've just mentioned, although I've got a national role. But in Glasgow, within the Alliance, we've got, I think it's 10 community link workers who work with GP practices. And they are the people who are referred by by the practice nurse or the GP. If it's somebody who's maybe wanting to attend an exercise class, or somebody who is isolated, or somebody who is wanting to engage with the outdoors more, it's that community link worker that they would be put in touch with. Or it could be somebody who's maybe got issues around they're not able, they've lost their ability to work full time or even to work at all, so supporting them sort of access benefits, whatever. So the link workers are absolutely crucial to this, and I know that there are link workers in Highland as well. Well, there used to be when I worked here. There's still.
There was only one.
There one, yeah.
There's a couple of organisations that have their own, but NHS.
Okay, okay. When I used to work in Highland, yeah, that there had
There was
been.
one in Aviemore.
Yeah.
It's funded.
Yeah.
He's doing
Yeah,
Monday a
yeah,
week,
but-
funded directly by community transport, but his own funding's gone.
Yeah.
And carers might have one or two.
Yeah.
funded.
Yeah, but these.
Carer link workers.
Yeah,
Or they-
yeah,
sorry.
yeah. But these roles are to me are pivotal, and I think
We all agree.
yeah, I think was a commitment in the last sort of chief medical officer's last report was, and certainly the cabinet secretary has said quite clearly recently that they aim to introduce and have 250 more link workers working across the country. But also, so that's Alice link workers and the self-management team. And I know that the self-management team were two of my colleagues, Rona and Marianne, were up here last week, and they were working with the Legwit, I can't say that, but you know what I mean, Legwit team anyway. And this is just a wee bit of, I've just put this in as a prompt to remind me to say to you that in the self-management team, I've got a self-management fund which is currently open for any sort of organisations who are looking for funding to support people self-manage. So that details of that are on the Lions website. We've got Self-Management Week coming up the 7th to the 11th of October, and when you're doing your introductions this morning, earlier on going around the table, I think there's a lot of you that could really put your organisations forward for that, to take part in that week. And I think one of the key events that we'll be involved in is the Self-Management Awards, which are taking place in Scottish Parliament on, I think it's the 7th or the 8th of October. And again, there's information about how to access the self-management fund, what resources are available, self-management week and the awards on the Alliance website. So I think I've gone 2.5 minutes over. I know the Highland way of life when it comes to timekeeping. So just really want to say is that I'm going to be here for the rest of the meeting. I've got these reports there, so help yourself. I've got a nice wee pictures of what the House of Care model is. I've got some leaflets, just some leaflets on like they're just sort of flyers we've used for More Than Medicine events. And also, when I mentioned about how the GP contract, this is a reports that we prepared on how the care and support planning and House of Care model is really a key enabler for the new sort of GMS, sort of general medical sort of GP contract. And I think gone are the days of QOF when they were sort of getting paid for ticking boxes, and that was showing how much focus they had on quality. But that's quite an interesting read for those of you who are interested. And also a plea that when I'm sort of organising the More Than Medicine event, which will be probably in the Aviemore area because that's where the taster sessions are taking place. It'd be really, really appreciative if you and your organisation could be represented, or if you think of any other organisations or any colleagues aren't here today who might be wanting to come along to have an opportunity to sell their wares and promote what they do, I'd really, really appreciate that. So, thank you very much.